Hi, class. Okay, let me just get all set up here. My name is Nurse Ann, and I will be the educator introducing this series called Competencies for the Postoperative Nurse. The series is for the professional nurse who is currently working at the bedside of postoperative patients. This unit of instruction will explore the more common diagnoses that lead to various colorectal surgeries, and it's going to focus on assessment, management, and care of these patients postoperatively. As you can see, some of the more common diagnoses behind colorectal surgery include Crohn's, ulcerative colitis, and just cancers throughout the whole bowel tract. So a little bit of background on these diseases include looking at Crohn's. This is a type of inflammatory bowel disease that has the ability to basically just like wreak havoc on your whole digestive tract from mouth to anus. Surgery is considered when symptoms are no longer manageable, even with medication or with bowel obstruction or fissure formation. As you can see by the picture, there are various types of Crohn's, and then included are just a long list of possible signs and symptoms of it. And then switching over to ulcerative colitis. It's similar to Crohn's in that it's another type of IBD. The difference is that UC is defined not only by inflammation, but with the consistency of ulcer formation as well. And again, there are 5 different types of UC and with the signs and symptoms listed. And then the last most common diagnosis is colon cancer, which can start or can be in the large intestine and go all the way to the rectum. And then these types of cancers are just the patients have an increased risk if they have underlying just colorectal diseases like UC or Crohn's or diverticulitis, as well as if they have an increased number of polyps. Looking at their surgical options, again, it's based off of the severity of the disease progression and just inability to control symptoms. Majority of the time, they just want to take out that diseased part. So various ectomies are performed, which are just resections based off of the size, location, progression of the disease, and you can see the various types right in here. Sometimes there can be an ostomy creation that's based off of where that resection took place. They're either permanent or they're temporary just to support the healing of that anastomosis site. Okay, and then moving on to nursing considerations. So these should support the protocol of ERAS, which means enhanced recovery after surgery. So as every nurse knows, the first crucial step is going to be assessment. So assessment of what? Assessment of the surgical sites and the dressings. Are they clean, dry, and intact? Is there any dehiscence from or out of the outer staples? And then assessing the GI system, so looking for the presence or listening also for bowel sounds, distension, color, size, and output of or from the stoma, and then monitoring for post-op ileus. Assessing the GU system, so monitoring for signs and symptoms of dehydration, so adequate urine output volume and color. And then kind of off of that is assessing the integumentary system. So again, signs and symptoms of dehydration. Is the skin dry, flaky? Are they pale? And then looking at the mucous membranes as well. Are they moist? Do they have adequate color? And then also looking at the skin around those incisional sites and the newly created ostomy. So once again, going off of that, intake and output are so important. So dehydration assessment, adequate urine output, looking at the color and the amount. And then oral tolerance. Is the patient able to eat? Are they nauseous? Are they vomiting? And then just assessing their overall general nutritional levels. And then looking at early ambulation and lung therapy. Which we all know lowers the risk of a post-op pneumonia, ileus, or DVT developing. So what we can do to prevent that is getting that patient to sit in the chair or to ambulate, or both. Post-op day 0, they may, kind of fight you against that, but too bad. Using the incentive spirometer and the flutter valve every 1 to 2 hours while they are awake. And a good general rule of thumb is if they're watching TV, say, hey, work on this every commercial break. So it's like 10 times an hour or so. And then with that, promoting coughing and deep breathing. Another important consideration is pain management, so that they're able to do lung therapy and to ambulate. So we're going to encourage and educate the use of pain medication, and then off of that, supporting the use of all scheduled non-narcotic medications with those PRN narcs for breakthrough, just to get the adequate pain control. And then obviously if their pain is not being controlled, really advocating for them and going to the provider to get that pain regimen adjusted. I'm going to do daily lab work so we can look at possible indications. So, monitoring for infection, we're going to look at their white blood cell count and their CRP. CRP is really more so inflammation, but we expect those two to be, increased post-op day 0 and post-op day 1, but then monitoring, making sure that they're going to be downtrending afterwards. We're going to be monitoring for dehydration from possible blood loss, so looking at their H&H, and then assessing their BMPs, making sure that their electrolyte levels are appropriate and normal, and repleting if need be, just to help with the healing process. And then last but not least, we're obviously going to be doing frequent monitoring of vital signs to assess for all those considerations that we just talked about, so infection, inadequate pain control, volume control. Okay, patient education should start post-op day 0. So Lovenox administration is not going to be for every patient, but patients that have a positive cancer diagnosis post-operatively are going to be discharged with Lovenox. So educating the patient and the family on that, and then how to administer it. If they have an ostomy, just care of that new ostomy, including proper hand hygiene. Good skincare around that stoma, how to measure the stoma, because it is expected to change size as time goes on. It should shrink. And then assessing the circulation of the stoma. Is it red, beefy, viable? And then just how to change the whole appliance and how to cut the flange, and then measuring the output of the stoma. And that goes hand in hand, all of that with the discharge instructions. So they're going to be contacting provider or the surgeon when or if their stoma output drastically increases, decreases, or just completely stops altogether. And that kind of goes along with inability to tolerate anything PO. So if they're nauseated, if they're vomiting, or just having this general complete loss of appetite. They're going to be looking at the urine output. Is it turning dark, amber? Is the volume decreasing? And then just changes of the stoma, so color changes, size changes, and then the generals, so like fever, shortness of breath, angina. And then looking at pictures that I posted. So here's one of the Lovenox injection, and then the rest kind of revolve around stoma care. So measuring the stoma and using that tool to look at their stoma size, and then connecting the flange and the appliance bag together. And then these other two are good skincare options, regardless if the skin is irritated around the stoma. I think Cavalon is always a good thing to use. I use it a lot, not just for ostomies, but if their skin has a chance of becoming irritated, whether it's with tape or any type of bodily fluids that are going to be sitting on the skin. Cavalon really provides that layer of film that acts as a skin protectant from any type of output. So in this case, it would be from stool or GI juices. And then stoma powder. It's pretty much used when the skin is already irritated. So what you do is you sprinkle it on around the stoma, on the skin, and then you use the Cavalon sponges and just dab at it. And that helps to seal that powder into place. So that concludes my presentation. I hope that everyone has learned at least one new thing or has gotten a really great review. Thanks so much.